So I appreciate your coming. Let's talk a little bit about overcrowding. Now, this is not a U.S. phenomenon, I don't think. The Canadians, you got some crowding issues there. The Australians, you have some crowding issues. Everybody's got crowding issues. In this country, we have them as well. But I don't really kind of understand it, because the thing is, we complain about being crowded. We say we're overcrowded. We created a new word, overcrowding. I don't think the word overcrowding existed, except we decided we would tolerate crowding, but we would draw the line at overcrowding. We would not accept overcrowding kind of thing. And so all of us are dealing with having too many patients, we think. And the only solution to having too many patients is to get rid of some of those patients. And I'm going to tell you why you don't want to do that, particularly in the United States. Or to see those patients faster, so that you can change, so you can rotate the tables in the restaurant faster and get more people in. Or basically get, in addition, have the people who are being held in the emergency department who need beds upstairs, we're holding them there to make those people leave and get the hospital to do something to facilitate those people leaving. Those are the only options. You can build a new emergency department, but that's going to take a long time, and it's not going to work. Because I'll show you some paper that said, we made it bigger. When they made it bigger, it got no better. It got no better. So this chapter was written by Peter Vecellio. In the United States, Peter is kind of famous for coming up with the concept of having people who are waiting in the halls of your department to be admitted to the halls of the upstairs departments. Now, have any of you embraced the Vecellio concept of our hallways are no different than your hallways? In fact, your hallways are better than our hallways upstairs. And have any of you embraced this idea? Oh, really? The Canadians? You put them up in the hallway there, kind of? Because there has to be kind of a threshold. And when that threshold is reached, you basically say, they're going up to your hallways, where then the nurses miraculously find a bed, that there wasn't there before, because they don't want those people looking at them and saying, where's my room, kind of thing. And we're just out in the hallway here, and everybody gets to walk by and say, how are you feeling today, kind of thing, So that has not been embraced very much in the United States, because they would like to contain this nuclear disaster we're having into the emergency department. Don't contaminate the rest of the hospital with these people in hallway beds. And so despite the fact that he has been preaching about this option, really very few people have adopted it. In fact, our nursing vice president, the one before this one that we have currently, said her words were, over my dead body. She really wasn't interested in moving the patients to the hallway at all. So we have the same kinds of problems now with patients who should be upstairs, not filling up beds where patients ought to be seen who are just emergency patients. Peter, in his chapter there, and I'm not going to read through that chapter particularly. You can read that at your leisure. It's one of those things that it's like you know ED crowding when you see it. It's like pornography. It's very difficult to measure necessarily, but the fact of the matter is when people are laying in the hallways and don't have any privacy to be seen, we know that we are now in a situation which we really don't care for. So what are people focusing on? Unnecessary visits. They're saying, well, you don't need to be here. You could go to a clinic. Well, the fact of the matter is that ER visits continue to rise every year in this country because we're delivering care under the terms patients want, when they want it, after hours. The baby's got a fever at 6 o'clock at night. Okay, let's go to the ER kind of thing. So unnecessary visits, we're not going to fix unnecessary visits. People basically are always trying to say, let's find other options. It really hasn't been shown to work. They also say that they're blaming people who have, the poor people have no insurance. They're clogging up the waiting rooms. Well, yeah, that's probably true. We do see a lot of people because there's no other place in this country to see the poor people who have no insurance. And frankly, it's a national embarrassment, that people aren't able to get seen when they have problems. We're the only country in the Western Hemisphere that doesn't have care for all of its citizens. And it is kind of, frankly, embarrassing. I think the Canadians and all of the other countries that have it are very proud of the fact that everybody will get care. We have been wrestling with this unsuccessfully for a really long time. So the emergency departments tend to be in the rob from the rich, pay for the poor, where we overcharge the people who have insurance to pay for the people who don't have insurance, basically. But it's certainly not a good way to do business. And then there's this issue about, in the United States, we have a regulation that says everybody who comes to the emergency department has to be seen to determine if they have a medical emergency, the EMTALA thing, because people were turning away patients from the hospital who are delivering babies, this, that, and the other thing. So EMTALA basically is an unfunded, and every hospital needs Medicare patients. So this unfunded mandate requires the emergency physicians and the staff in the emergency department to see these patients. And all of these things are believed to be contributing to overcrowding. But there are other ways to look at overcrowding, and I would like to suggest that we can deal with this problem in a couple of ways that seem to be pretty straightforward in the United States. Can I ask any of you, do you know the length of stay in your emergency departments for a patient who is being sent home? The average length of stay for a patient who goes home from the emergency department is how long at your hospital? Anybody? Anybody? This number is crucial that you know this number. Crucial that you know this number, because we did our course in Orlando last week. There was a hospital that's where the length of stay for discharged patients was an hour and a half. Hour and a half. That was the average. And the average for the admitted patients was 3.5 hours. Extraordinary by most people's circumstances. They say, well, how did this hospital accomplish this tremendous goal? The fact of the matter is that the hospital said, we're going to accomplish this goal. We want these patients to come to our hospital. We're in an affluent area. We're not going to tell anybody you don't belong here, and we're going to give you good service, because to a certain extent, we are often embarrassed in the emergency department. We have all of these plastic chairs for you to sit on and wait for a while. Can't you see we're busy? We'll get to you when we can. Sit in the plastic chairs kind of thing here and spread all of your germs around to everybody else. We're going to treat you like we're afraid of you. Will you go up to the window to register? It's like a 2-inch bulletproof, thick lucite, very warm, welcoming kind of environment kind of thing to visit, for patients to be seen. Yet, if they go in the front door of the hospital, big marble donor wall kind of thing, all the padded chairs are in the lobby. They don't have the pink ladies there surrounded by bulletproof lucite, but the people in the emergency department, we're afraid of them. They're dangerous. They might hurt us kind of thing. And then we basically make them wait. We don't give them much in the way of privacy kind of thing. And we clearly give the impression that we are doing you a favor. And we'll get to you when we can. We are doing you a favor. Can't you see we're busy? But there's another question that is I need to ask you. So you don't know how long it takes you to see a patient. And my contention is we need to see them quicker so that we can see the ones that are waiting more efficiently. And the next question I must ask you, and the Canadians and the Australians will not have an answer to this, but the docs in the United States should. What does a patient bring to your hospital in terms of dollars for a patient who goes home? A patient goes home, what does your hospital collect on average for a patient who goes home? Anybody know that? Nobody? It's $428 at our hospital. Every soul who goes home brings to our hospital $428. And that answers the question, who's doing who a favor? Once you know that it's $428, you want every one of those souls to come in. Now, at your hospital, it might not be $428, it might be $300, maybe $250. But I can show you that at $250 a patient, if you can see somebody in 2 hours, your hospital will not be a loser. Your hospital will be making money. You should not be complaining, and you should make every effort to see every patient you can. This hotel probably charges $250 a night to stay here. You get to stay here for 24 hours. You get to stay in a nice room kind of thing with a flat panel TV kind of thing, and they're only charging you $250 to stay here 24 hours. We're going to charge you $250, and we're going to collect it for you to be in our department 2 hours. And you can't tell me a business like that cannot be considered to be highly successful. Yet we are whining. We got too many patients. We have too many patients. One of the things I would like to do today is to give you some information that you could take back to your hospital that not only relates to the financial parts which we talked about, but I would like to show you that our emergency departments, because we make people wait and because we hold them there, it is affecting the outcome of these cases in terms of we are increasing the morbidity and mortality of patients who we see in the emergency department and hold there. There's been some nice studies recently that we've looked at in the database that basically say and I'll show you what they are, that patients who stay and are held in the emergency department will be staying longer in the hospital, and that, in fact, the sicker ones will have an increase in their mortality. Because this is the kind of information that we need to basically say to our administrators. We need to show them that, number one, there's medical reasons for these patients to be facilitated to get out of here, and number two, the quicker we see these patients, the better off we'll all be. Let me take a break now. I don't want you fellas standing in the hallway there. There's some chairs here. And I did apologize already. Tomorrow we're in the bigger room. There's some chairs over in the corner here of the church. You're welcome to come to the front of the church. Come on, guys. It's okay. We're all friends. I want you to sit down, relax, be comfortable. There's a couple of spaces there. There's a couple of spaces at the end there. So let's just look at a paper or two here. Bedside registration. This paper number 1 is really typical of what you find out in terms of how staff can torpedo good systems. So here's a paper where they had they talked about bedside registration. And at baseline in this hospital, number 1, it took them 42 minutes to get a patient from triage to a room. 42 minutes. They just said, okay, let's do some bedside registration. And this is going to make this much quicker. And sure enough, yeah, it did make it a little quicker. It went down from 42 minutes to 31 minutes. They saved 11 minutes, which is not very good at all, frankly. But what happened over time? Over time, the staff sabotaged this, and within a short period of time, they were back to 40 minutes. It was made no difference that they were doing bedside registration. At our hospital, where we started bedside registration a number of years ago, the staff said, nope, we're not going to do that. No, we have to be here in front of our computers, kind of thing. We have to enter the data. So basically, we're going to do it on our terms rather than patients' terms, despite the fact that all the VIPs, they don't go to the registration window. They don't talk through that bulletproof lucite glass. They all come right in. You know, the VIPs always get a bed. Registration comes to them. And I remember people coming to our hospital to see, how do you do this bedside registration? I said, don't bother. You do it right now. It's called what happens when an ambulance comes in. When an ambulance patient comes in, somebody goes over with a clipboard, takes down the information, and then actually goes back and enters it into the computer. So they all do bedside registration. They just don't do it universally. The idea of getting a patient into an open bed and having registration come talk to them, and then having somebody come in and see them, and so that you're doing parallel process rather than step 1, step 2, step 3, step 4. Most of your emergency departments, you go to the window, you say, I want to be seen. You say, fine, okay. Go over there. We're going to triage nurses are going to check you out and determine whether you're going to live or not. Once the triage nurses have determined your head circumference, your toilet training, and all of your religious preference, you're going to go back into the waiting room again until we have a bed in for you in the back. But we know you're going to live now because the triage nurse checked you out. Now that you can come back in the emergency department, we're going to put you in a bed. The EMT is going to put you in a gown. Another nurse is going to ask you all the same questions all over again, and the doctor will be the 5th person to see you, no matter what's wrong with you. Now, you talk about that process. Most hospitals, that process will take you 45 minutes to an hour. No matter what, you got an empty hospital. It's going to take you 45 minutes to get seen because you have to see all these people and tell them your story over and over again. Bedside registration is essential. How many of you do bedside registration now? Okay, it was kind of considered to be a radical concept, but gradually it has been embraced as that's the way to do business. That's the way everybody would like to be seen. That's the way your relatives would like to be seen. They don't want to go out window and talk there and tell them about what's wrong with them through the lucite kind of thing. In our hospital, we had when I came there in 1985, they were building a new emergency department, and they were going to put in, but it was a 1960s design in 1985. So they had a counter. You would go up to the counter and tell the registration clerk what was wrong with you, kind of thing. You want to be seen in the emergency department. And in that counter, they had built in, and it's still there now, these little things here where you would be able to put your insurance card through because they were going to put the 2-inch lucite up. And I thought, 2-inch lucite? Yeah, well, these people are dangerous. We can't be talking to these people. So I got them to stop and not put the 2-inch lucite up. So now at the hospital, there's the counter, and there's these little things where the lucite was going to go so you could stick it under. And then one of the clerks said, I think that this is an unsafe work environment, and that's all you have to do. You say that phrase, they get the security analysis done, and now we have the bulletproof lucite back because somebody thinks it's an unsafe work environment. Not one person has been hurt at our hospital since 1985, yet did we make it into Fort Knox because we were afraid of our patients. It's really an embarrassing thing. And yeah, some of them are kind of nutty, but the fact of the matter is that if they want to get you, they'll get you. If you treated their mother bad and they want to get you, they know where the doctor's parking lot is. They'll find you in the parking lot. You see these things happening every once in a while where doctors are assaulted by relatives of patients that you killed. That simple, security system they have in your department, that's a charade. But in any case, it's a concern. It doesn't give the message I think that we want, that this is a helping environment. We want you to come in. We are your friends. And you're not any different from the people who come into the lobby. This paper basically showed that the staff torpedoed bedside registration. Well, what about making a bigger ER? That's obvious kind of way to solve this problem. Number 2, Vanderbilt, 5-month study before they built their new ER. Then they built their new ER, moved into it, waited 3 months, and then looked again at how things were going in terms of the big new ER that they built. They went from 28 beds to 53 beds. There was no change in the number of ambulance diversions. There was no change in the time spent ED length of stay for both discharged and admitted patients. They increased the staff. It's like, how could you possibly do so badly? These papers say, we'll show you how we can do badly. Number 3 is kind of interesting. It's basically, if your administrator falls for this one, you need a new administrator. This paper says, listen, if we stopped holding these admitted patients here, we could see more other patients. And if we saw more other patients, we would bring in more money. So that if you got these patients out of here that you're blocking this emergency department with, we would, 30% of the admits were in the emergency department more than 2 hours. They looked at how much hold time there was over a year. It was almost 11,000 hours. And they said, geez, in 11,000 hours, we can see a lot more patients. And we would make $3 million more for more admitted patients and more patients who go home. So the fact of the matter is that this was an attempt to motivate the administration of the hospital, say, listen, you're clogging up this place. If you unclog this place, we could see more patients. The assumption is that there are more patients to be seen, which is one of the fallacies in this argument. But the fact of the matter is that there's no question we need to turn the tables in our restaurants quicker. And I can tell you, 5 years ago at our hospital, Grace and Ed will testify, our length of stay for discharged patients was 2 hours. And our length of stay for admitted patients was 3.5 hours. Our length of stay now, seeing almost the same number of patients, is 2.5 hours for discharged patients and 5.5 hours for admitted patients, which means our nurses are doing more, spending more time with these patients, even though we're not seeing substantially more sets of vital signs. Can I go to the bathroom? When's lunch? All of these kinds of things, another reassessment is going to be done. More documentation kind of thing is being done on patients who don't need to be there, who could have been sent out of there when the department was more efficient. So the idea is, what is a reasonable goal? A reasonable goal clearly is 2 hours for a discharged patient. Sprained ankle, laceration, foreign body in the eye. If you can't get them out of there in 2 hours, then there's an opportunity there, because you can. You absolutely can. Admitted patients, more of a challenge, because basically your workup is done and you're holding them. 3.5 hours, reasonable goal. It was the goal that we set for Catholic Healthcare West, 42 hospitals in the western United States. It's an achievable goal. Somebody says, get these simple cases out of the emergency department and just keep the harder cases. Send them to the urgent care center. Paper number 5 says it's not the simple cases that are causing the problem. Now, they went through a lot of machinations to prove it, but I would agree, and especially if you want to be a little bit cynical about this and say, that's a 428. We don't call them patients anymore. That's a 428. Bring that 428 in. Let's get some more help to see the 428s. You'll never say, well, we can't afford a tech. Another tech? What's a tech cost? $20 an hour for a tech? One patient who leaves without being seen is $428. You can buy 20 hours of tech time for one patient who leaves without being seen. And the national average for leaving without being seen is about 3%. Some of our Catholic Healthcare West hospitals had 6%. 6% of their patients left without being seen. What kind of business would tolerate that kind of thing? And you say 3%, that's 1 in 33 patients. That's not bad. That's terrible. That's terrible when you convert it to, that was a 428 that just left the building. They could have bought more time for additional staff. Most of these hospitals are substantially understaffed. If you staff for the average, that means 50% of the time you are understaffed. You staff for the average, because all these hospitals have fluxes, especially the smaller hospitals, their fluxes are quite large. Staff for the middle means that you are difficulty time seeing the patients who are, when you come in, that are above average that day. The other thing is none of the staffing rules take into consideration severity of illness, length of stay, percentage of admissions. So I can tell you, as an example, Catholic Healthcare West, they wanted 2.4 employee hours per patient across the system. Well, we admit 20%. Some other hospital admits 10%, that kind of thing. So you have to take into consideration acuity. How long are you holding these admitted patients in the department? That's all work that's being done. So this was a very, very crude measure, and yet they thought that was the way to go. It was like embarrassing that anybody would think that that's the way to staff an emergency department, is based on something like that, when there's such variability between departments. The Australians basically helped this out with an idea called access block. There are a couple of papers that the Australians did, and you guys ought to be proud of this. We should have been writing it about a long time before you did. Number 7 is an example. Access block is defined as being in the emergency department with admitted patients more than 8 hours. And basically, this paper showed that the longer that the patients were there, their length of stay in the hospital did not decrease. And as a matter of fact, I'm talking about paper number 9. They looked at almost 12,000 admissions, and when the people were in the emergency department who should have been admitted were there 8 hours or longer, the length of stay went from 4.1 days for an average length of stay to 4.9 days. So they seem to get no benefit by being in there longer. And the administrators in the United States are concerned about length of stay. Well, here's a paper that says, take this to administrators and say, listen, you keep these people down there, they're going to stay longer. They're not going to get out of here quicker. They're going to stay longer. And the other paper they did was number 7. This is a paper that basically looked at length of stay, access block, and what the admission rate was at the hospital. And basically showed that the higher the admission rate at the hospital in terms of its percentage of occupancy, the longer the patients were likely to stay in the hospital. And the other thing is, there's 2 papers that say the outcomes are worse. Deaths attributed to prolonged length of stay in the emergency department were 2.3 per 1,000 admissions. So it's not only length of stay, it's mortality. And the best paper on this is one that you don't have in your paper, in your manual, because we just did it. And it is a paper from, but you need the citation, Critical Care Medicine, June 2007. It looked at 50,000 critical care patients treated between 2000 and 2003 in 120 United States ICUs. And it looked at, and this was done by the Society for Critical Care Medicine, huge study, and they looked at the subset of patients who were held in the emergency department, ICU patients held in the emergency department, 6 or more hours. That was only 2%, which is really, I don't think that that's the current number. But when this was done, it was 2%. What was the length of stay difference? Those ICU patients were in the hospital 1 day longer. Okay, but no big deal. ICU mortality, 10.7% in the group that were held in the emergency department 6 hours or longer versus 8.4% those who went up right away. P.01. 10.7 versus 8.4. The total inpatient mortality, when they got out of the ICU, went to the other wards, 17.4% versus 12.9%. A 5% absolute difference. 1 in 20 patients were dying in association with being held in the emergency department. Now, was that because the whole hospital was full and the nursing staff was too busy on the floors to take care of them? Clearly in association. And Dr. Hoffman, who does these papers with me, said, there are ways to criticize this paper in terms of its methodology, but frankly, we like the message. The message is ICU patients held in the emergency department may be at risk for worse mortality, and that's the message you should give to your administrator. Don't let them, they won't be able to ferret out what's wrong with the study. Just tell them these people are more at risk. You're going to kill these people if they're down here, kind of thing. So this is some information that you could take back to help our dysfunctional departments. Turn the tables faster, not hold the patients. There are financial consequences and morbidity consequences associated with doing that. All right, let's stop here. Go ahead. Jerry, you want to come up?
Are you saying that it's been demonstrated that the cause of their increased mortality is
No.
the length of the additional length of time they spend in the ER? Or is it those sick people, that's why they were in the ER longer?
No, we're just saying that there's an association between staying in the ER 8 hours or longer and an increased mortality. It probably means the hospital's full, probably means everything else is being stretched, et cetera, et cetera. But all we want to do is tell our CEO look at these people are going to die. Hold them here in the emergency department. Don't let them give you, well, maybe these are other reasons. Our goal is to get these patients out of the department and where they need to be. And we can talk, there's a session here that we'll do 3 days from now where we talk about things that have made your department faster, more efficient. And we can go through some of the more specific things that people have done to be able to turn these tables. Go ahead.
How do you incentivize staff that are on an hourly wage to work harder to get more patients in?
Question is, how do you incentivize hourly staff to move quicker and get the patients out? It's interesting. There's a hospital in Seattle where the emergency group is taking over the employment of the entire staff under the approval of the CEO, because there is this issue about mismatched in terms of motivation kind of thing. More and more doctors in the United States are paid by their productivity, RVU-based compensation, et cetera, et cetera. Some doctors here in Los Angeles only get paid based on what they see. There is no hourly in terms of their salary. At our hospital, we have about 25% is based on productivity. So yes, there is this disconnect because you bring in more patients, the staff has to do more work, et cetera, and nobody's been able to seem to solve that really well. And so here's an experiment that's going to go on that says, how do we do when everybody is equally incentivized? There is an issue. Everybody will bring it up.